Good afternoon and welcome to the webinar. Interoperability and Patient Access, a New Age of Healthcare Revolution. This is David Nays, Chief Medical Officer at Innovacer, and I'm pleased to moderate this session. And we're going to talk about how do we think about the digitalization of healthcare? How do we really get healthcare, the healthcare revolution that we've always talked about where other industries are at? So with me today, I'd like to welcome Phil Fasano. Phil is a Fortune 100 C-level strategist. He's a former Chief Information Officer at Kaiser Permanente, American International Group, and many others. So Phil, welcome.
Thanks, David. Appreciate it. And I didn't know I was a C-level strategist. That's a new title. I'll take it.
I like it too. And also Mike Sutton, Chief Technology Officer here at Innovacer and former CTO at Kaiser Permanente, and many others that we'll talk about. So Mike, welcome.
Thanks, David, appreciate it. Kills me how these people find these photos of me. I've never seen that one before.
Well, Mike, we know that you love the nautical venture, so we see a boat behind you. Picture.
Yeah, very good.
Yeah. So let's get into it. Phil, you know, we talk about the future of healthcare and that AI, artificial intelligence or augmented intelligence, is going to change everything, right? And there are other industries that have really begun to tackle this in a very significant way. It's new to healthcare. What are some of the similarities in other industries? You've worked in a couple, financial sector, et cetera. What are some of the similarities of healthcare to the other industries when it comes to where AI may play a role?
Well, it's a complicated question, not an easy thing to answer just in a succinct way. So I'll give you a couple thoughts. You know, from my history and the things I've done in financial services and in healthcare, when you combine and look at the two, it's all about the data and having your hands around the data that's important to the problem you're looking to focus on. Whether it's, you know, in finance, trying to model a security and trying to make some money in the markets and beat the next guy by using a whole bunch of data that you can get from public sources and some of your private sources, and then using some AI tools to enhance your insights. Or if it's dealing with a patient who has heart disease and really needing to have your arms around that patient's data and everything that relates to that condition. And then being able to use AI to, you know, basically surface some insights at the moment of truth when a physician or clinician is interacting with that patient and it really matters the most, where it can support either their intuition about the patient's circumstance or enhance their point of view about that patient's circumstance to a point where it can make a difference in outcomes for the patient themselves. So there's so much about the data, and it goes from there. And it isn't always having all the data or having perfect data, but knowing enough about what you do have and what you do know to take advantage of it, to glean insights and really make a difference in healthcare, in particular for the patient. In other industries, you know, we always look to see what insights we could gain, and often before someone else. So I'd leave you with those thoughts, David.
No, that's right, and I think we all experience this. Both of you have heard me talk about when we all drive a car, we have our smartphone there, and Google Maps may say, oh, there's an accident ahead, turn right, you'll save 13 minutes. And that's an example of an automated recommendation and actionable information you can take. And in many cases, like potentially a self-driving car, can be automated. Now, Mike, you joined Phil at Kaiser several years ago before you came here. And you know, that was your first time exposing yourself to healthcare organization. How do you see the use of data and eventual artificial intelligence different in healthcare from other industries?
Yeah, that was, you know, my whole career has been in, you know, bringing data together and integrating data. And, you know, arguably, whether it's, you know, counterterrorism data when I was with the Central Intelligence Agency or consumer data and travel data when I was with the cruise lines, the thing about that data is very discrete. It is very self-defining. What I have found, and it took me 7 years to discover it, is the contextual use of the data in the healthcare practices is much more sensitive. There's systolic blood pressure rates at rest, or standing, and in motion. These are three different things, and you have to know that context of how those readings were taken. And so the data has a much more complexity around it. And then I think the term that's being used in the data world in the healthcare space is semantic normalization, because when we get these readings, if you take readings as the example, and there's many other cases like that, when you get these readings from disparate systems, a lot of people are using fitness type devices now for some of these measurements, and there's clinical devices. You need to know the context of that data, because eventually, and just like that second bullet says on there, a physician is going to make some decision off of this, and in some cases it could be hazardous to one's health to make the wrong assumptions of what the context of that was, or it might misprescribe some sort of medication. So to me, the sensitivity, the contextual sensitivity of that data is not what you generally see in other industries. And then the importance of that data in making the right decisions is probably most relevant and most pertinent in the healthcare space.
Mike, hearing you, would you mind, David, hearing you say that? I think the other thing that I think we probably all agree on is when you think about data in healthcare versus other industries, and how the other industries have used data and AI tools for quite some time, and in many cases without that concern of harm. To help them with decision making, or in certain cases, obviously there is the element of I have to land a plane. The data that's in telemetry that's coming in through everything from flaps and everything else are giving me insights, and I do want to land that plane safely. But when it comes to healthcare, there's that extra added feature of needing to do the right thing for the patient, and we're only scratching the surface on the potential of both what we can do when data comes together and we actually know enough about it, and we apply the now very modern artificial intelligence tools to that data to do some really great things in the healthcare industry. So I think the potential, and I wanted to use the word potential, there's more potential for what we'll be able to do in this industry over the next decade than many of the others who are even, may want to call them mature, although they're still not as mature as they should be either in many cases. I'm sorry, David.
No, this is great. I mean, both of you have such great experience and insights, having come from outside of healthcare with your, information technology and data expertise. We have a lot of people, a couple hundred people on the call right now on the webinar. They're healthcare experts, and they're going to want to hear from you. And so I'm going to ask our audience, as you have questions, please put them in the chat box, and then I'll bring those questions forward as we go along or toward the end as well. So we'll want to hear from you as well. So going into this, let's get a little bit more into the complexity. When we talk about applying AI potentially to the data we have in healthcare, what are some of the issues we need to think about? Mike, let's start off with you.
Okay. So I think one of the other kind of characteristics of the healthcare industry is there are, the industry is fragmented by itself. There's payers, there's providers, there's labs, there's pharma, there's many, many, many players in it. And each of those players have their own healthcare vendors. And so we have really not hundreds of applications. In fact, when Phil and I were at Kaiser Permanente together, the number, which is greatly reduced from where we started, was we had 1,800 applications that were necessary to interoperate with each other and share data amongst each other in order to conduct the functions of applying medicine to our members. And that's that's kind of the healthcare side of it. But the IT side of that is that's an incredible amount of combinations and permutations, and not all 1,800 needed to talk to all the others, but the ability to pass data between these. And like I mentioned before, they're not using the same language as they communicate with data. The Cerner EMR is different than the Epic EMR is different, than in our case the PDX pharma system. they have much of the same data, but it's described differently. So, and I think we all kind of understand it's very hard to apply AI when you don't have a common data, and I'll use the word model, a common data model to operate from. AI is just going to make bad decisions. And so getting that data right and all those arrows you see on that slide, getting them so it's connected and that the algorithms have something to work from is really a very daunting task for the IT departments in these healthcare, health provider, health payer organizations.
Bill?
Yeah, I mean, as I think about this and just think about what we did do at Kaiser, you know, looking back on it, while we were doing it, it felt like we were doing a high wire act with no net. It was very hard and complex. It was extraordinarily difficult. You know, Mike, you mentioned the number of applications, you know, not to mention the number of people who were involved, both in entering information, making sure it was correct. And then, you know, even after they did that, us having to do the automated, you know, kind of work that we did to ensure it was truly, you know, accurate before we pulled it all together. Pulling that together was the most complex endeavor I ever, in my career, was a part of. We all knew the potential, we all knew the opportunity, we all knew what we were striving for. And in the end, I had the privilege of leading the IT organization and being involved with many other parts of Kaiser, and having that one voice who could say we're going in that direction, so let's all go. And we all had the ability to do that. The world doesn't work that way. It isn't homogeneous. It's lots of different systems. It's lots of different organizations. It's frankly lots of different you know, reasons to go in different directions and desire it your way. Yet, from a data standpoint, when we're thinking about the potential for AI in healthcare, bringing it together for the purposes of doing some of the things on this page, precision medicine, population health, and then, you know, biomedical machine information, and being able to pull that in as well and have real-time insights, which is a game changer in many hospitals and in many emergency departments. And having AI take away the artificial, you know, the noise from the signal, and really helping clinicians in those circumstances deal with patients when they're in their most acute issue, having the most acute issues. But it's all about bringing this together, and it's not together, and we know that, and that's a huge part of this challenge, and it's going to continue to be a huge part of the challenge till it's solved. And I think, you know, part of, you know, what you know, I'm involved obviously with you know, this organization. I know what they're doing. There are many people trying to make everything interoperate, as if we were dealing with a beautiful orchestra and there was one conductor. In this case, it's not quite a beautiful orchestra and there's many conductors. And we all have to find a way to harmonize those to get to the place we all know we ultimately can be with respect to data, insights, and then ultimately the transition that leads to in healthcare for better health.
No, that was well said, Phil. And, you know, as we go through this, tracking the questions from the audience, you know, we're going to want to have you each speak to thinking about, like, it's easy to be a spectator and agree that interoperability is something we should all have, right? But what can each individual member, each stakeholder in that picture really contribute to advancing the concept? So let's first think about this question of, you know, for your organization, just to take a read of the audience here, you know, what percentage of your peers do you believe in your organization truly understand the opportunity for AI in healthcare? So please select the appropriate response, and we'll pull up the results in just a minute. You know, I really like what you were describing about the complexity and the data, and the types of data, unstructured, structured. Can you speak to identifying and correcting bias in the AI algorithms that one might apply? Like where might that bias lie when applying AI across these data sets? Mike, let's start off with you.
Yeah, so I think, you know, and, you know, maybe the kind of the precursor to that is, you know, we kind of talked about the complexity of this interoperability, but I think we're very bullish on using AI and machine learning techniques in the curation and kind of to your point, David, of kind of eliminating bias in that data. So, so one of the things that, you know, I think is important as we go forward with this is how does the data, very good standards are evolving in how we share data. That to me is fairly objective. And I think in those particular cases, bias is not, to me, I might be wrong on this, it might be controversial, but I don't think bias in the data is established during the messaging of information. So the FHIR APIs are out. I do not think that possesses bias. I think where we get into the complexity and perhaps the bias is when we start, you know, applying referential integrity to that data as we persist it in different data stores. And I think it's important that as we evolve these, and I'll be a little more specific on that. Historically, what we've done in the healthcare space is we have a problem, we have a need, we have to do HEDIS reporting, or we have to do claims reporting, or we have to do pharma reporting. Each one of those became a separate data model, a separate data warehouse was a separate data supply chain. There's an incredible bias in there because it was built to solve a single problem. And even though they're using the same data, because of the bias built into these referential models, it produces different results. That's clearly not good from a data science perspective or as a business analyst perspective. So I think it's very important that, you know, as this concept that's evolving, you know, in kind of what I used to call the big data space, is that we have a unified data model that is persistent and consistent to solve multiple use cases. And that inherently will reduce kind of the biases that are introduced for solving particular problems.
So Mike, that was very helpful. And in fact, I think if I let you say all that, before we took this poll, the results might have actually changed, but here are the results. Here are the results. This is interesting. Again, that 0 to 20% might have gone way up if you would have said that beforehand. But this is interesting. I mean, very few organizations feel that their peers really understand the opportunity for AI, not just AI issues of bias. So, Phil, are you surprised by these results?
You know, unfortunately, I'd say no. It actually, having lived the life I did within Kaiser, I mean, we were so focused even then on using the AI capabilities of the day, and they were rudimentary compared to what's available today to solve problems. I had the privilege of I always reflect on this, I had the privilege of being in an exam room when we were using AI to predict basically time in terms of duration of lifespan for people. And to tell them with reasonable accuracy, we had determined we were about 95 to 97% accurate, that we could predict based on certain conditions and people's behaviors and lifestyles that they would only live a few more years. And the intent obviously was to change behavior and help them live quite a lot longer. But you know, that was a very early days of using AI in an exam room. We were doing it at Kaiser, I want to say 10 years ago. So, and there was many other examples of things like that we would do because we could. And I said this earlier, I had the privilege of being able to direct, and I could be directive and prescriptive in what I wanted from the company and what I wanted for the company. And then the words I would always use with my IT team was, we need to make it so. And that's uniquely different than what exists in as I said earlier, the wild, where everybody's out there and working to different purposes and not as focused. And there is no single person typically that can just say, we're all going left now. And left means we're going to go and take advantage of all the data we know we have and the data we can obtain and the great technologies of the data to benefit our patients in different ways. So it's not surprising in that, you know, to me, at least we're not as an industry that focused on leveraging AI and the possibilities that it portends for health and healthcare. We're very focused on doctors and patients and what doctors can do for and with patients and what other clinical staff and folks can do with patients, which is all the right things to do. How can we, and I always used to say, how can we make every doctor the best doctor in the world? And one of the ways we can do that, frankly, the opportunity in healthcare is the combination of data and AI in support of great and, in fact, fantastic care by every doctor, because now they have all the insights in the world that they just can't go and research on their own. They can't do that discovery. They can't do, go pursue the data, and they can't then do the analysis that needs to be done, that could be done in an instant by the kind of technologies that are out there today for their benefit and for their patients.
No,
So,
those are great insights, and I agree with you. And it's funny. One of the people in the audience just said that the elephant in the room they think is CMS, who can help drive this, and we'll get into that in a minute. So you've all covered the kind of challenges in interoperability, right? We showed that complicated slide, and we're going to talk about this concept of the final rule, the CMS rule, that's really helping to push this forward. So let's start to get into that. How are we going to solve some of these challenges, because they're quite significant. Mike, you started into the first industry that had practical implications, right? Specific implications in the travel industry, which digitalized quite some time ago. Share with us some of the experience you had from seeing the genesis of interoperability in the travel industry.
Sure. Thanks, David. Yeah. So I was working in the cruise line industry. It sounds weird to say at the turn of the century, and what happened was, this was prompted by a lot of kind of the .coms that were coming out, the Expedias of the world, the Travelocities of the world, and there was a desire, and there was a feeling that the industry had the ability to be able to provide direct service, direct access to consumers of travel. And so we got together, many of us competitors. I had my good friends that were competitors in the cruise space. Certainly the airlines were involved, the hotels were involved, the rental car agencies were involved, and I was part of the working group that was coming up with the common format for exchanging travel data. And interestingly, when we first started in 1999, we agreed. And this was just like you imagine any industry group together where you have competitors in the room. There was a lot of discussion, a lot of debate, but we came up with 4 APIs, application programming interfaces. But we all agreed, all the industries, and said, let's start with the very, very basics and define what a trip is. I mean, because that's what we're selling. We're selling rides, and we started with 4, and it certainly expanded. But what happened then? That became the genesis for opening up some transparency and self-directed access by consumers themselves and their ability to decide and book their own travel. And there were conversations, and so this was the very beginning. It was a technology-led thing, but then there were things because now we were producing APIs that were available on websites, available through Expedia. There was now a new level of transparency that drove changes to the way we priced and sold products in the market. And it wasn't just the cruise line industry, it was rental cars, it was because now it's an open market. And so it changed basic business models in the travel space to where it's evolved to the point today. There's a lot more than 4 APIs. It also enabled a lot more, around that same time, there was a lot of evolution around travel security. So there was a lot more security that now we could provide because we knew had better manifest information. And anyway, this evolved to where we are today, which I don't know the last time I ever had to pick up a phone to book travel or book a holistic vacation. So my premise has always been, although much more complex than travel, the healthcare industry could benefit from that same amount of ability to share information with all the players in the industry and provide some amount of transparency to help shape business models, because I think most people agree that the business of healthcare is probably not as functional as it could be, to say it nicely.
So Phil, you've been around the block for a long time in this industry, the technology industry and healthcare. Like Mike just described, open APIs of revolutionizing the travel industry. That was quite some time ago. Some of us remember that opening up. Don't we have APIs in healthcare, and what's been the barrier?
Well, we do have APIs in healthcare. In fact, we have so many of them with limited standards that bringing data together has been a horrific exercise. I can think again. I'll think back to when I was at Kaiser, and we actually tried to crack this problem by creating something called the Care Connectivity Consortium. You guys can look that up in the old, in the history books. We knew it wasn't going to be an easy thing to do, and we only pulled 5 major organizations together across the country to do it, and we worked on it together. We put a lot of effort into it. We put some money into it. I always used to say it's just math. We could figure this out. We do not have a unified patient record. So even discovering who Mike is in one organization's health record versus another was an enormous challenge. So it's an industry that really needs to do an OTA across the industry. But there's other ways of doing it with science and math and really smart people doing the kind of work that I know you are and others are to get the interoperability problem solved in healthcare. But it's been an extraordinarily tall hill.
Yep, there's no question about it. And if you look at the current state of things, I think this kind of portrays why interoperability in healthcare matters so much and how much we can do. Mike, you want to just take a stab at describing what you see when you see this kind of result of the percentage of patients or labs data that's shareable and open?
Yeah, and so it's been eye-opening for me because, we're talking a lot about Kaiser Permanente, but one of the advantages there, we did have a closed loop system with our lab systems. We owned our own labs, we had our own pharmacies, and as I mentioned before, Phil had us make sure these systems were well integrated. So it wasn't uncommon that if I went in and had a blood panel done, that I was getting responses within an hour in some cases, the more simple tests. Some of them took a little bit, but I would be getting them real time because we had our own, again, internal APIs that were, as those specimens were processed and made available, they in very near real time showed up on my membership application that I had. And so first of all, that's, if you think about it, medicine is a service industry, and this is providing a service to a consumer that provides a lot of confidence and credibility in that. And it's been very surprising to me now working in, outside of kind of a closed system, that people don't have that same advantage. And so the ability to get this data, in fact, now, since I'm outside of the Kaiser system, I don't get to see my results until I go see my PCP like a week later. And so I think, when we talk about expectations of consumers, I think that device that we all carry around with us has driven a lot of expectations that I think healthcare is falling very short of in solving the problems. And then I even, kind of based on some of the the fragmentation in the business, if you're seeing a specialist, they don't necessarily get the labs from your PCP. So you have to go do another set of labs for your specialist. So this just drives inefficiencies in this business, I think, a lot. And interoperability could help solve that.
Yeah, and as we've all mentioned, the feds are really starting to push this. As you think about, why regional HIEs in the past, have failed because of their business model, the feds are trying to push it. Whose agenda are we trying to meet when we talk about interoperability? Is it the provider wanting to provide better care for the patient? Is it the patient wanting to take ownership over their health data? Or is it really the payer trying to reduce costs and make sure that care is less costly and more efficient? Bill, what do you think?
Well, I think it's the first time we really said payer here. And I think it's important to say that because that's a whole nother dimension to this discussion, right? It's all, you have to say it's all of those. And, for me, I always would put the patient in the center of everything we were trying to do. And I did that because I could understand and have a lot of empathy for a patient because I'm one myself. And frankly, always felt that, I like a little more control. I'm a kind of a control-oriented person. So in that view, I felt I wanted more control over my healthcare, and the things that we did when I was at Kaiser were oriented around that quite a bit. but they were also oriented around, how can I always believed there was a way to make every provider great. It's there by having interoperability. And then from the payer side, I mean, you have a whole nother abundance of information and insight. Even, and I'll say this, in Southern California, if you are a Kaiser patient who needs a bone marrow transplant, you go outside and you're not in the Kaiser system, you're in another health system. And that's kind of an important element of your care and frankly, your follow-up care. And there's no way, it was very limited methods for repatriating those insights. So your physicians inside Kaiser knew about it. And fundamentally, it's quite an important part of your care and what happens to you next and how people are treating you inside Kaiser. So even for that system, it's a difficult challenge. Just looking at the three folks on this page, everyone should benefit from the work and the elements around data sharing. The one other piece, and it's from the prior page, and I'd say this about savings and things like that. As an industry, if we can actually get to interoperability and get some financial savings, you have to believe that the industry can redeploy those in a way that creates some really amazing outcomes and unique and entirely different possibilities for health, particularly in the United States. But then the impact of that is that the US becomes a huge beacon for the rest of the world. I think that's the kind of work that this country is known for, in all the way back to the 60s when we were striving to put people on the moon. We should be kind of gathering ourselves around this as an opportunity to really be a beacon for the world by changing outcomes for patients in this country in a material way, because we're changing all the behaviors around data sharing. And everyone in this picture benefits, but the patient benefits the most, and overall the country benefits the most.
Yeah, I think you shared with us before we got this webinar up and running today that $30 billion is a dramatically low number, and that other people have said it's 1 to 1.5 trillion in savings. And if we do that, then we can start to really sort of do things we've always wanted to do in healthcare around improving care. And it really is about the patient. And it's really about bringing everybody together onto the same page, bringing a regional ecosystem together. And the fact that the HIEs of the past have been unable to fulfill that dream. So CMS is playing a role. They're trying to really push the card on this and laying down the gauntlet. Mike, kind of tell us a little bit about what you've learned about this new interoperability rule from CMS.
As a technologist, I mean, to me, this is the what's the Wizard of Oz, the trail of gold leading up to the ivory tower. What I'm 100% certain that metaphor was wrong, but the fact that the government has gotten together, and it's taken a number of years to do this, and they've been out for review for well over 5 years, probably even longer, that they've come up with 146 FHIR API resources that to me probably it's a big piece of what we use today and consume in this interoperability business. But they've come up with a very well written specification on how these application programming interfaces should be used and specified. For specifically for the ruling that was applied was to provide patient access from the payer's environment for their membership. And so this is, to me, a huge first step. July 1 is the date we're all working for. We're, at Innovacey, we're being very fortunate that we're working with some payers in this particular environment to move this forward. And we're very happy and proud to be part of this because, like I said, to me, again, from a technology perspective into the business of medicine, is the ability to provide this transparency and openness. This is, a huge step. And if we're going to use the moon landing, it's one giant step for mankind, I think, of getting these things out. But it's not without some complexities as we kind of, climb this path, and kind of get to the full environment. But it's to me, a great first step. And
Phil,
you know,
I'd love for you to comment on this. Given this rule, and some people in the audience have brought up that I mentioned that the former, and there's still a few, health information exchanges have not really been successful. And yet now we have this open API and this CMS mandate. Why is it that the HIEs in the past have not been so successful? And where is there a glimmer of hope, if not a big dramatic hope, given these new rules and APIs and how they might be used?
Yeah, David, I'm glad you said that, frankly, and I'm sure people will take exception to the whole thing on the HIE. I mean, I was at Kaiser when that stuff started, and my forecast was that they're creating any smaller entities in the country at a regional level to try and be a central repository to bring patient data together was at its core a flawed exercise. And we chose not to wait at Kaiser. We chose to do. And by doing, we actually created great outcomes and connected a lot of very complex systems. What CMS has done with this, and by creating the standards and created essentially all of the APIs, or many of the APIs that the industry needs, it's laid the groundwork for, I'm going to continue the metaphor myself, the moonshot, and the moonshot in healthcare in the United States, where we actually can be a data-based activity with facts driving our insights and insights driving our outcomes. And that opportunity, in my opinion, is one of the largest opportunities in the industry right now. Now, I know people could debate me and say, look, it's the genome. Look, it's in every respect, even in the genome work, it's all about the data and it's all about the insights. And then ultimately, it's how you analyze what you find, what the spectrometers and other things give you, so that you can ultimately get to your conclusions and leverage that knowledge and leverage that discovery. There's going to be so many discoveries coming from this that we're just going to go, wow, we never thought that was possible, because there'll be so many simultaneous types of discoveries in healthcare that are for the benefit of patients in a material way. And then, by the way, the whole process of managing disease, caring for patients, interacting with patients, we're going to learn a lot about how to change that process for the better as a consequence of this, because we will again be data-based and data-driven, and we'll be able to understand how to make things simpler, how to make things easier, and in many cases, how to eliminate some of the things we do today that really aren't giving us only giving us incremental value. We'll have jumped way past that from the data itself and the insights we're getting from that data.
Yeah, and I think, one of the folks on the audience have brought up about, how will this be used by different players? But let's take a quick poll and check in with our audience again, and then we'll get into that. How has your focus within your organization been changed in terms of improving patient access and enabling true interoperability? Either you don't have a plan right now to leverage these new CMS rules, you're still learning about them, you've made a plan, but we haven't really got it clear yet. We've made a plan and we've had to sideline it because COVID happened, and that's happened to a number of people. Or we have a plan and we need to accelerate it very quickly post-pandemic. So new rules, they dramatically will change the industry, these interoperability rules. And there's a question for payers, for providers, to have a plan in place. The goal, obviously, is to get true interoperability in healthcare. So while we're waiting for that poll result, please go in and put your answers into the poll. One of the goals here of these new regulations, Mike, has been to allow patients with this, because we all carry these, right? These smartphones by our side, to be able to choose their own application. And just like when I download a meditation app or a retail shopping app or whatever, I can say, yes, I'm giving you access to my data. Really, isn't that really the goal, is to empower patients to be able to use the application of their choice?
Yeah, 100%. And the one thing that if you remember back in March, there was a lot of talk about, wait, if we give all people this access, we're not going to be able to protect their data anymore. So before I kind of answer your question, in my opinion, having some background in the securing of data, is that this mechanism of sharing data via APIs is tenfold, maybe 100-fold more secure than the way we were sharing information before, with huge batch jobs being sent between different facilities, it gets landed, it may or may not get, secured in that environment. So, and we're able now at a very, very fine grain, at this message level in an API, protect people's data. And one of the big functions that have to be built in as part of this sharing that with the payers is consent management. And it gives actually the patient and the member, total control over what data gets shared by whom. And so it really does put, to me, the patient, in control of their own data. And having said that, is out now all these third-party apps, like you mentioned, the meditation. Well, to me, there's so much innovation that goes on in this app space, and I couldn't see you, but I'm sure you were holding up your mobile device. I am certain there are innovations in not only the practice of medicine, but also in the business of healthcare, that we're going to see so many innovations popping up now that this data has become available, because we're going to get hundreds and hundreds of more innovators being able to improve the way healthcare is delivered because of this availability.
No, that makes a lot of sense. Well, let's check in with our audience and see and pull up the poll results and see if people are ready to leverage these interoperability rules. Well, this is encouraging. Phil, I mean, sounds like at least 30% of people have a plan to leverage these rules.
Yeah, it is encouraging, actually. And I think, as with any of these changes, there's some time involved. So people do have some time, and obviously not too much left, but they have more time than we had, before. And they're well defined. In fact, now they're even better defined than they ever were. So organizations know what they have to do. So even if people on this video don't have a sense for some of that, there's someone probably in your organization that's thinking about this pretty deeply, and maybe even working on it. And maybe you're not connected with that, but if you're someone who runs IT and you're in the we didn't have a plan and we still don't, you're probably needing to develop that plan pretty rapidly.
So there's a lot of complexity to this rule, as I mentioned previously, and I skipped over this slide on purpose, but right around the time that this rule was to hit, COVID happened, and it took a lot of people their eye off the ball, and CMS has accommodated to some extent, but obviously we all know this, right? COVID happened, it really impacted us in a big way. The hospitals shut down, ambulatory care started doing telemedicine, we alleviated those rules, but this issue of interoperability still sits there as we moved into sort of the be able to deliver care at home environment, and now we're able to get these rules. There's a lot of complexities to these rules, and I have to share, David Nash, and I hope he doesn't mind me sharing this, I don't believe, we've been friends for a long time. He's built often known as the father of population health in this country, building the first college of medicine. When we did our first interoperability announcement about the federal rules, he said, I don't even know about this. And this was like 7 months ago. So as Mike said, a lot of this stuff has been distracting. It was quiet behind the fields, but this is going to revolutionize the industry. So Mike, walk us through sort of the timeline, because there has been some alleviation because of COVID. Walk us through the timeline that we're going to have to think about in this dramatically impactful move to creating the superhighways within healthcare from CMS of this mandate.
Sure, David. So again, it was approved. Well, I guess officially approved in March, the March 15th, 2021. I think that, I'm sorry, where's 2020? So it was officially approved, this spring that we had to go ahead with this. And a big part of this is showing there, June 2020 is a big part of that regulation is the interpretation of what data blocking is. And there's a lot of, in the details discussions of when these third-party apps start being developed, what is the role of the payer in protecting their members from unscrupulous app developers? And so, and data blocking is part of that, because if you start saying, well, I'm not going to allow this third-party app to use my data, that could be construed as data blocking. So there are a lot of interpretations with that. The big one, the patient access for those APIs, the official date is January 1st, 2021, with enforcement starting in July of 2021.
Mm-hmm.
And then we can kind of just go on to then the other very important one is with the payer-to-payer data exchange. That starts in January of 2022. And this, if you can imagine, now every person that has healthcare insurance in America is now, we're not going to have the ability to collect all that information, with these payers sharing that information.
So once again, we're going to make these slides available to all members of the audience. So no need to quickly, take screenshots or write notes. So we'll get this to you. So because there's a lot of stuff here, and this is really impactful. There's a good question from 3 audience members, Phil, which I think they'd be interested to hear your result is. What is the incentive? And Mike may have mentioned it, but let's just reiterate it. What is the incentive for the large EMR vendors, Epic and Cerner, to share their data and insights to help participate in this transformation? What is their incentive in this process?
Well, I think there's carrot and stick in this process, I think, at this point. But that's been the largest question for the past decade, if not more, with those 2 vendors, but others as well. Because there's this, I've had it expressed to me by some people that it's their data, and we all know that's not true. In the end, it's the patient's data, and and the institution needs to use it obviously for care or for from the payer standpoint for claims, but ultimately it's really about the patient, and they are pretty much being told in this that they're part of the ecosystem. They're needing to deliver the APIs and work to these dates as well and support this as much as it pains them to do so, which I think in many cases it does. But this is the beginning of the industry opening its data up and making it transparent across the industry, which then creates a real opportunity for others to do some great things. And I think Mike talked about, organizations that create, apps and other things, but it's also institutions to do some great things around clinical care. So, and at the end of the day, when you listen to the altruistic purpose of those 2 EMR vendors from their CEOs and others, although they do make a good deal of money, there is that need to do what's right for the patient. And this is absolutely right for the patient.
No, I couldn't agree with you more. And, I often draw the analogy of Amazon because, all of the retailers, if they want to participate in the marketplace, have to have APIs, right, to be able to access the platform and make their goods available to consumers who get to choose and go on and shop. And what a lot of people don't realize is all the way back to supply chain, to manufacturers, all those folks are on that platform. So that it's very clear when you go on, is it available? Is it available now? What do other people like me that are shoppers, what is their experience in getting it? All of that stuff has opened up. And so the whole shopping and retail and wholesale behind that supply line, it's all available for the different members of that system, ecosystem, if you will, to be able to learn from and participate and evolve the industry. And so in healthcare, what are the key components of a comprehensive platform that might get us to the same thing? Let's start off with you, Mike.
So these are, to me, the 4 fundamental capabilities that need to be put in place in order to, to get to this, this interoperability using those FHIR APIs. And the first one is, is connectivity to the data within those payer environments. And I'd also add on there, many of the payers are trying to get more clinical data. And so it really kind of to your earlier comment about, the big EMR vendors, there really needs to be, even at this stage of the game of interoperability, that participation from the EMRs are well. But the payers are big, complex organizations with a lot of data and a lot of environments. And then, and what I have seen so far, they're actually quite competent at managing that data. But we need connectivity and access into that data because that's what we're going to expose. The second thing there is FHIR, F-H-I-R, is the spec that needs to be built to. So in order to do that, and one of the main concerns that has happened early on in this whole FHIR compliance is that bad data is going to get communicated to the wrong people, and that'd be a very unfortunate mishap. So in our opinion, you need to have some sort of a server and a gateway that consolidates, aggregates, and cleans that data before you start sending it, outside of, the security of a payer's environment. Thirdly, the intent of the open access to those APIs is to allow third-party applications to develop. So there needs to be a portal set up. There's a lot of compliance and legal decisions required by the payers on, I mentioned the one is, are they going to prevent certain third-party apps from accessing their membership's data? Are they going to play that role, kind of a gatekeeper, a safety gatekeeper for their members, or is it going to be open to everybody? And that requires some amount of certification on the payer's part. And also, consent's in that one too. And the other one, as I mentioned too, is that the member gets to decide what data gets presented, because they may not want all their information, and there's complexities around delegation, there's complexities around giving access to your data for a payer program you were with, prior, in 2017. So you have to be able to get legacy access as well. So there's a lot of decisions that need to be made in that area. And then finally, I've already mentioned this one, I missed it. The membership workflows is helping the members decide who gets access, who they're going to delegate it to, how they can withdraw at any point in time if they're not happy with what one of those third-party apps has done. So it sounds a little complicated. It sounds a little just kind of these four basic capabilities are required for a interoperability solution.
And this is just a breakdown of the patient access interoperability rule. We will make this available to all the members so they can see how this vision will be achieved. But I mean, going back to the idea of a platform, certainly we here at Innovacer often see the platform. This is what we conceptualize when we do it. Let's start off with you, Mike, and talk about sort of this issue about where the data can come from, because this is really the key to getting to AI. And then we'll go to Phil to talk a little bit about AI, and we have questions from the audience. Mike, walk us through the importance of how this data ingestion, curation, and then what I often call harmonization is all about.
Yeah, and those are the three big parts of our solution. And the first one today, so let's get real for a second. The FHIR standard just became a rule in March. So many systems on that left-hand side are producing data in that FHIR API format today. And so you have to be able to take it in any form that you can get it, whether it's an HL7 message, whether it's a CSV file, a CCD file. We even do PDFs, and then some people have already started. Some of the EMRs are producing some APIs that we can use today. So, but in order to get a comprehensive view for that patient, we need to take it in any form that it comes in. And then secondly, and then that middle part is the curation and unification part. We feel very strongly that if someone were to take their data directly from a transactional system, and no disrespect meant to anybody, but that data is not always as high quality as you might hope or suspect. And so we feel strongly that there has to be a curation process that goes through, that cleanses the data, classifies the data too, because in many cases those EMRs, there's certain types of data, as you talk about consent, that may not be categorized correctly, that you want to prevent distribution of that information. So that categorization has to happen in that middle step as well. And then no data is worth its while if we can't activate it, and that's what the right-hand part of that is. And certainly, getting it to not only, we talked a lot about third-party apps, but there's capabilities with data scientists, there's capabilities with practices that want to transform their membership's experience. All of that can really become reality now that we're giving them these 146 API resources. There will be more, but 146 is really good, considering the humble beginnings of the Open Travel Alliance with 4.
You know, Phil, this has been a great walkthrough about how Mike walked us through the data being brought in, how that will change with these new rules as people adopt these FHIR APIs, how data can be harmonized and then unified, but then given to the members of the ecosystem to really help them innovate. And a lot of questions in the audience about how do you prevent Murphy's rule, which is an unintended consequence, right, of having all this AI applied to this? And then also, how do you assure the confidentiality, the HIPAA, how do you ensure the confidentiality of that?
Well, on the latter, HIPAA has to be assumed throughout, right? So that has to be foremost in this, in ensuring that data privacy is managed at every point of handoff and can be ensured through technology as much as anything else. Obviously, if I take my screen that has patient data on it and I show it to you, Mike, it's hard to prevent from that. But if I'm, involved in this ecosystem, I have to be assured that the data is high quality, that the data has been managed in a secure way, and that no one else could either put any data in there that doesn't belong or take that and use it in a way that's not intended. On the AI, I'm going to go beyond the AI a little bit. I mean, connected care in this whole framework and being able to ensure that everyone who is involved with me as a patient has the same insights, data, and ability to know what was done to me before, either done to me or for me, either lab results or other tests, or what someone else in the ecosystem may have said or interacted. Having those pieces of information universally available and in a secure way ensures that the old adage where I had to bring my file folder with me to every doctor or every new interaction with a health system I ever did, that's a thing of the past. We're now in a seamless world where information is commonly available about me to the people I want it to be available to, and that yes, AI can be used, and so can some of the normal analytics and other ways we used to do this in the past. Just simply providing insight and information so that people know what was done before and know they don't need to do it again. And so, you talked cost earlier. A real connected care framework will also just naturally take cost out of the entire ecosystem, because we all will know that the data and have the data in common and the information about the patient in common as we go around that circle. So best care becomes one of those things we can all provide in a very consistent way.
No, great comments. And, just the last question I want to bring up. In this post-COVID world, we've moved to telehealth. We've started to think about the timing of this new interoperability rule and the FHIR APIs. Last comments from each of you. Where do you think this will head us? We've talked about value-based care, and yet we continue to have a largely fee-for-service business. COVID has set things back for many of the hospitals because they've had to focus on COVID patients. People were afraid of going back, and they use telehealth. Now people get comfortable with that. Mike, do you think this will dramatically change the way we think about the delivery of healthcare going forward? And then I'll go to Bill at the same time.
Yeah, real quick on this, David. I spoke to one of your peers, the chief medical officer at a fairly large healthcare system, and his comment was, I've been in this business 30 years, and my whole goal was to get my patients to come in so I could develop care plans. And COVID turned everything around. And look how the healthcare industry, we should be pretty proud of ourselves as a industry. Our operating model turned around in a very, very short period. Really, kind of not seen before in the healthcare space as far as rapid adoption of very significant change in the way we operate healthcare. And so to me, I look at that as, kind of, maybe it's a little Mary Poppins moment, but I'm very bullish on the fact that the realization of how these IT systems could help support that change is going to be a trend that continues in the future.
Phil, quick comment. Change the future dramatically?
I think it's both radical, but I think the opportunity is better health, and it's universally better health. It doesn't matter who you are. It democratizes better health for everyone in every community in the country and frankly around the world, which is has always been the opportunity a lot of folks have strived for. It's now well within the grasp of the industry.
Well, as a closing comment, I want to thank our audience for coming. Phil, I love that last comment because we are, democratization is what we've always been about here. Let's do it in healthcare. Thank you both very much for coming, and thank you all for the audience for participating. We'll be in touch. This concludes the webinar. Thank you very much again. Good day.